deep, and then there is a shallow groove on the right side. Always mark your ureteric orifices whenever there is a median lobe. So once we have identified the anatomy correctly, we start with the median lobe enucleation. I call this as a mushroom technique. So we have to mushroom all the lobes one by one. So what I am doing is I am doing an incision at 5 o'clock and 7 o'clock on the left side and the right side. So that way I am mushrooming or compressing the median lobe from both the sides. So I am doing it here. So I'm working on the left side, and here I am now using that sweeping motion. So I am compressing that median lobe from right to left and left to right. So now you can see there are hardly few fibers attached at the bladder neck. And once we do that, the median lobe gets enucleated exactly like what it's okay. I'll manage. Don't disturb. So after taking down those final fiber attachment, the median lobe goes into the bladder. The moment median lobe is enucleated, it helps us in two ways. Number one, if you're doing first few cases, it will do a huge good to your confidence that you have done something creditable. Secondly, there will be a lot of improvement in the fluid dynamics. So once we take this median lobe, your fluid dynamics will increase. Now we are taking down the 12 o'clock incision. Right at 12 o'clock, we have to be quite careful whenever we are coming from bladder neck to proximally. We have to make sure that we should not be progressing beyond the veru, and there is no veru, so you have to have a landmark which mimics the veru on the 12 o'clock. Then what I do is again mushrooming from 12 o'clock. I am coming down, so I've almost come down to 1, 2, 3 and 4 o'clock. So the entire lobe has been displaced from above down. Once that is done, then I start from below and I start my incision, which is at 5 o'clock, and then I gradually sweep the lobe up. So from 5 o'clock I am going to 4 o'clock, 3 o'clock. So from both the side, from above I am displacing it below, and from below I am displacing it up. And once we meet that, the final few fibers are there, and we can completely enucleate the lateral lobe. So this looks quite easy, and the important thing about holmium as an energy is, there is hardly any jarring seen like we come across in thulium fiber laser. So you can easily identify the transverse glistening white capsular fibers, and you can maintain that plane, and you can repeat the same procedure on the left side, and that's how you can tackle down the entire prostate. So friends, the concerns with this Peter Gilling's conventional technique was you have to identify plane 3 times. First at the 5 o'clock, then at the 7 o'clock, and then at the 12 o'clock. So you have to make 3 incisions. And mind well, holmium is not a very good cutting tool. It's a very good dissecting tool. It doesn't cut well. So it takes a lot of time to incise these tissues at 3 level. And secondly, there can be mismatch. You are coming from above downwards, match exactly. Both the planes should match exactly. Otherwise, you can go superficial at one level and deep at another level. Then there will be size mismatch. So this is the problem with this technique. And the 12 o'clock incision is very, very important, because if you go too shallow, it can result in cutting through the adenoma. If you are too deep, you can actually go in the capsule and do a perforation. And if you are taking it too distally towards the veru, then you can actually incise the external sphincter, and that can lead to sphincteric incontinence. So because of that, there is one more new therapy came, which was new kind of technique came, which was called as en-bloc enucleation. Why en-bloc? Because you need to identify plane only once, and this mimics the open surgery. What we do is we do a commissurotomy at 12 o'clock. In en-bloc, what we do is we do at the 6 o'clock, and then we do not go anywhere else, and then we just keep identifying that plane. So what you need to do is you have to identify plane only at one plane, and then without any further cutting, using the Holek bubble, the laser bubble, you can dissect it and enucleate and dissect everything. The one more important aspect is that there is no undue stretching of the sphincter, because you are dissecting and not cutting. There will be hardly any concerns of sphincteric incontinence. So this is one more small clip of en-bloc enucleation. So what I'm doing is I am taking down a 6 o'clock incision. I am going vertically, and what supramental TURP does, the same thing we do in Holek is called as ejaculation preserving whole laser enucleation of prostate. So we preserve that 1.5 centimeter bullous area proximal to the veru, and then I am dissecting it laterally. So what I am doing, I am lateralizing both the lateral lobe. Here there was no median lobe, so what I am doing is I am lateralizing both the lobe away from the ureteric orifice, so that there is a large kind of hollow cavity created, and that leads to better fluid dynamics. So you can understand what I have done on the left side, now I am doing on the right side. I am sweeping it laterally, making sure that it goes beyond the right ureteric orifice. It helps in the terminal part. When we are enucleating last few attachments, we don't have to bother about potential threat to the ureteric orifice. So that's what we do. Now this is the 12 o'clock incision, and then now you see this is the most important aspect. This is the apical tissue which we can cut very precisely and without any sphincteric injury. So once we do that, we match the incision on both the side and completely separate that from 12 o'clock. And lastly, these are a few attachments at the bladder neck. Once we take down the entire adenoma, like what we get in the phrase prostatectomy, the entire adenoma is one piece. So there is no piecemeal kind of thing. So friends, there are a few concerns. In a very large median lobe, you cannot do that. In a very large gland, you might get lost in the plane because the tissue keeps falling on you, and it is really difficult to master. So in early part, you cannot do that. For that, what I have done is I have found out a very easy thing. It's an Y approach or X approach. So I'll show you in a kind of pictorial thing. So this is what is Y approach. So if there is no median lobe, you start vertical limb of the Y at the bladder neck, and once you reach 1 centimeter near to the veru, then you sweep and take down lateral incision. So that becomes an inverted Y approach for a bilobar enucleation wherein there is no median lobe. If you encounter there is a median lobe, then you cannot do this Y because center there is a median lobe. So what you can do is you can call it as an X approach. You start at 7 o'clock, come to the midline, again diverge, and on other side from 5 o'clock you can come to midline, again diverge. So this will take care of median lobe as well as the lateral lobe. This is a small video of the X approach. There is a large median lobe, so I am marking the ureteric orifice, and at the same level, that is the 7 o'clock, I am giving this incision up to the capsular fiber. Then I am coming, withdrawing it till I reach to the midline, and then I sweep laterally. So this becomes the right limb of the X. We start at 7 o'clock, come to the midline, and diverge on the lateral aspect, so that lobe starts getting enucleated. And this is the Y approach, wherein this is 1.5 centimeter colliculus seminalis which I am preserving there, 1.5 centimeter away from the veru, and then I am marking my Y limbs. So this is on the right side. I reach up to the desired part, and then do the same thing on the left lobe of the patient. So I am extending that Y limb on the left side. This is called as a dihedral groove between the lobe and the veru. That is where the planes are easily identifiable and very, very shallow. So this is the Y limb, and then this is the vertical limb of that particular incision. So I take it down right from bladder neck up to the previously marked region, so that I don't go into the seminal colliculus. The rest of the thing is quite same. So I'll just keep this video for the want of time. So lastly, we cannot learn like couple of these sessions. We cannot learn whole like this session or